Hi, everyone. I'm Sharon Ben-Or. I'm a thoracic surgeon in New Jersey. And this is David Rice. He's a thoracic surgeon from a small institution you may have heard of. And we're here to moderate Thoracic Expert Session 2A, Lung Navigation Planning Virtual Reality. And our first speaker is Luis Godoy, talking about single anesthesia navigational bronchoscopy and surgical resection.
All right, great. Thank you all for being here bright and early after a potentially long night, like some of our other colleagues who I won't mention. I'm Luis Godoy. I'm from UC Davis in Sacramento, California. For those of you not familiar with the geography of California, so UC Davis is the northernmost UC campus in California. And what's unique about our location is that we have a very large catchment area of about 33 counties. So we see patients anywhere from the Oregon border, Nevada border, Central Valley. All of these patients get referred to UC Davis, to our cancer center. These are my disclosures. So this is a common patient scenario that we typically get from some of the outlying community providers. This patient, 58-year-old man, 30-pack-year smoker, had an incidental right upper lobe lung nodule that was found after a car accident. He ultimately underwent a PET scan, which showed some mild uptake, good functional status, excellent lung function. He lives 6 hours away from Sacramento. He was first seen in telemedicine consultation, and in addition, he also saw our interventional pulmonary colleagues as well. And plans were for biopsy. However, his local hospital, their local radiologist, felt that it was a challenging and high-risk location based on their facility. He had difficulties with travel, so we discussed his case, and I'll tell you guys what ultimately happened to this gentleman. So there's a variable pathway for these patients when they show up to your clinic. So you get this incidental finding, they see their primary care provider, they get referred to either interventional radiology, pulmonary medicine, IP for bronchoscopy and potential biopsy as well. And then anywhere along the way, from the time they get referred to a specialist to the time they get scheduled for a biopsy and ultimately get a diagnosis, that can be anywhere along 3 months or so for some of our patients, even longer for some of our rural patients. So the question is, can we bypass this system utilizing ION and Da Vinci combination? So can we avoid these several weeks of waiting for tissue diagnosis before proceeding to surgery in a select group of patients? So I probably am aging myself with this cartoon here. I don't know if you all are familiar with this cartoon, but this is Voltron from like the 80s. So robots coming together, these individual smaller robots coming together to form this larger, more powerful robot. So by combining these two, we can produce a similar type of effect and create a more effective, more efficient method of biopsying and diagnosing these nodules and ultimately treating them. So back to our patient. We discussed them at our multidisciplinary tumor board. There are these lung nodule risk calculators. I don't know if you all are familiar with those on the STS website. I tend to use, for these patients that I'm planning to do a navigational single anesthetic surgical procedure, I use these calculators to ultimately come up with a risk of malignancy. And in a patient like this, who's a longtime smoker, with some hypermetabolic activity and these features, speculation, there's a high likelihood that it's a malignancy. We then, at our discussion, decided to proceed with a single anesthetic ion biopsy, followed by lobectomy if confirmation of lung cancer. I put here with these asterisks, we discussed with this patient, also consented the patient for a possible diagnostic wedge in the event of a non-diagnostic biopsy as a backup. And if you look back at the CT scan, the nodule is up in the apex. Many people will say, well, why don't you just do like a diagnostic wedge and avoid the ion biopsy and wedge it out and get your diagnostic biopsy and then resection? The reason is we're starting, this was our very first patient. We're starting with a new technology. We want a relatively straightforward, large target in the area that we have that backup where if we get a non-diagnostic sample, we can fall back on the traditional wedge biopsy followed by surgery. So as part of our planning, for this first procedure, we assembled a team. Our pulmonary colleagues at UC Davis are very, very active and very aggressive with their interventional program, and so they're the busiest providers using ion. And so I partnered with one of our pulmonologists to bypass some of the learning curve and get the tips and tricks. This is Dr. Fan standing next to me up here. He's by far the highest volume ion user at UC Davis. And utilizing his knowledge and tips was essential with trying to get a successful procedure, especially when you start at the beginning, you want a highly successful procedure. So this is our team down here. We have some reps here. Harmick from Cedars and his team came down to help proctor as well. This is our typical room setup. As you can see, it's quite crowded. We have C-arm, bronchoscopy cart. We have the Da Vinci robotic boom kind of tucked away in the corner. We don't necessarily drape it immediately. We wait until we get our confirmation. And then the back table, again, we don't set that up until we get our confirmation. The one thing that we do have at UC Davis is we have a cytopath in the room. So as we're getting these samples, we're passing them off to the cytopath technologist who's analyzing them in the room while we're getting additional tissue. That way we keep things moving pretty quickly. Once we get our tissue diagnosis or confirmation, the C-arm, ion, the cytopath, everything leaves the room, and so now we're back to our standard operating room. So this is what Intuitive wants you to believe, that these procedures look like, right? There's no cables or lines or anything like that. In reality, this is what it looks like. So you're tripping over cables, you're kind of tucked away between these. You got like a little fortress of bronch carts and equipment around you while you're doing the procedure. So it's not quite as spiffy as it's shown on the previous slide. So this is our patient when we're doing the navigation. So we're following this GPS map all the way out to the nodule. As you can see here, we're within 10 millimeters to the proximal extent of the lesion and 23 millimeters from the distal extent of the lesion. Ideally, when we target these for biopsy, we set the needle to meet somewhere in the middle so that you're getting into the center of the nodule. This is how we do it. So we use fluoroscopy. We don't have the CT scanner set up yet. There's a integrated scanner that can be set up with ion. We don't have that quite yet. So we're still using fluoroscopy. I use radial EBUS as well to verify that we're in the center of the nodule as we're getting the samples. So innovation utilizing these technologies can lead to a paradigm shift. So our typical 8-week standard from diagnosis to surgical management can be really shifted, really truncated, utilizing ion. So for this particular patient, from the time that I saw the patient in telemedicine visit to the time that we saw him in the operating room for his procedure, it was about a 3-week period. So we had the majority of his workup done at his institution, what could be done there. And we were able to get the diagnosis and the biopsy, the diagnosis and the surgical procedure all within a 24-hour period, and he ultimately went home the next day. Other examples of how we're using ion in these single anesthetic procedures, so metastasectomies, I think is one of the areas that this is very helpful. So this particular patient was 37 years old, had a history of rectal adenocarcinoma, had previously undergone a right lower lobectomy several years earlier. He had a CT surveillance 2 years after his lobectomy, which showed some new right upper lobe nodules that were suspicious for metastases. Excellent functional status. We presented him at tumor board as well, and the concern from our radiology colleagues were that the nodules were too small to biopsy, so one of the options was to just watch and wait, try to get a biopsy, but then there's a risk of false negative in the setting of a high likelihood for metastases, given his history. So the recommendation was to proceed with ion mapping, marking, and wedge resection of these lesions. So these are the lesions in question. As you can see, they're in the outer third, the periphery of the lung. And again, the reason we wanted to do this is to preserve the patient's ultimate lung function. We wanted to avoid part of the discussion was, why not just radiate these if they're small? Well, he has a high likelihood for recurrence in the future, and if they're in an area that are amenable to resection, we should just proceed with resection. And so that's what we did. This is a brief video. I won't go over the entire video, but after navigating out to the nodule, we can mark the area and then ultimately resect it. So the patient went home on post-op day 1, less than 24 hours from his diagnosis and treatment. The final pathology did come back as metastatic rectal cancer. He's doing well and is currently on surveillance. So again, the benefit for this very young man was lung preservation, avoiding more invasive procedures with localization, and save future radiation doses for potential recurrence. Segmentectomies, this is another area where ion can help as well. This is a complex segmental anatomy of the lung. And I showed the entire video of this yesterday, but we can see this patient with this confirmed cancer at the apex of the lung. And you can use ion to mark that lesion as part of our procedure. We can see the demarcation here of the devascularized tri-segment of the left upper lobe, or some would argue a bisegment of the left upper lobe to ensure adequate margins here. And then other common clinical scenarios. So this superior segmental GGO that had grown, the solid component had grown on surveillance, and options that were presented to the patient were biopsy, which he underwent. The biopsy was negative. However, we knew that this nodule was evolving. And so he was referred to us, and the plan was, the discussion was, since it is evolving, it's in an area that's amenable to segmental resection, can we navigate out there, biopsy the lesion, mark it, and ultimately resect it? And that's exactly what we were able to do for this patient. And then other scenarios. So this is just one patient that I was looking at the other day, and you can see this is severely emphysematous lung. This nodule up at the apex here, I'm not planning to navigate out there, but this is just an example of treacherous territory for CT-guided biopsy, given the severe emphysema and the high risk. So lesions in this type of lung parenchyma are easily amenable to ion biopsy and ultimately resection. So why is this important to us? So I added this slide yesterday because I just got this email yesterday. This is from one of the interventional pulmonary conferences that's coming up. And as part of their outline here is fire and ice, so ablative modalities and tips. So this is important because this is an evolving technology. It's very early on. It's kind of analogous to when cardiology was starting with intravascular stenting and now they're doing valves. We saw the other day they're starting with mitral valves and tricuspid valves. And so it's important for us as surgeons to stay on top of this technology because down the road there will be navigational ablation, potentially navigational delivery of treatment. Who knows, brachytherapy seeds, might be placed in these nodules down the road. Like we don't know what's coming along the way. So it's important for us to be up to speed on this technology. So is this for everyone? Easy answer is no. Patient selection is key, especially when you want to start a brand new program. You got to have a high index of suspicion for malignancy. Otherwise, you'll book an entire OR day or a case for a biopsy that ends up being benign, and then you've lost your OR space. So you got to have a high index of suspicion. Patient factors are key. Nodule characteristics are important. That's why I use the pretest probability calculators. And then all of these patients get a multidisciplinary discussion as well. And then there's just patients who say, no matter what, even if it's benign, I want this out. So these patients are good to having these types of procedures because it not only allows you to navigate and mark these areas, but it serves as a repetition. So the reps, getting reps in navigating out to these areas is important to get over the learning curve as well. So the era of precision lung cancer is here. By combining these platforms, we can streamline patient care. We can decrease the wait time from diagnosis to treatment, decrease the patient and family anxiety, which is probably the most important factor that we've gauged from the patients who have undergone this procedures. We can increase the precision and likelihood of anatomic segmentectomy. And this is an excellent option, especially for our patients who travel long distances, who can't be coming down every couple of weeks for procedures. And especially in the setting of where our institution is. And then there's going to be, this is just the beginning. There's future endoscopic treatments of these lung nodules. And so it's just the beginning of this robotic bronchoscopy era, and it's important for us to be a part of this. Thank you.
Thanks, Luis. I'll open it up to questions. Just a reminder, because we're videoing this, just introduce yourself and your institution, please.
Great presentation, and we, I think, strive to create more patient-friendly pathways for diagnosis and treating early-stage lung cancer. My question is regarding lesions that may not be amenable to wedge resection or segmentectomy. How do you approach these lesions? We are always worried about having this big setup, and we're thinking we're going to get our diagnosis, but then cytopathologists don't always feel comfortable making that diagnosis. How do you approach those lesions? Do you have any tips for that?
Yeah, that's a really, really good question. And one of the biggest factors is having the patient informed. And as part of our consent and in clinic, we discuss the potential for, just like in traditional, you might end up doing a lobectomy for a benign lesion, right? So this is all part of the informed consent process. We discuss that with the patients. Every time we map out a potential biopsy with ion, there's multiple routes you can create using different bronchioles to the lesion, so that if you don't get a diagnostic sample from one angle, you might be able to get a different angle. So that's key. The preoperative planning is key. But you're 100% correct. What if you get a non-diagnostic sample? in an area that's not amenable to wedge resection? And the answer, like we used to do previously, is you weigh the risk of it being a malignancy, and ultimately the discussion is that we may end up doing a larger resection for potential benign finding. So it's all part of discussing with the patient and as a tumor board.
That's great. A follow-up question: do you use cryo biopsies for these, or just needle? I thought about potentially sending for frozen. Is this something?
Yeah. So I use the needle and the cyto brush. So the one thing with this, it's got a 2 millimeter channel. So once you've punctured the bronchial tissue with the needle, through that same hole that you've created, you can pass a brush into the lesion and obtain cells. In addition to that, you can also pass a grasper through there. So we've passed our grasper through there, and we're able to grab pieces of tissue and have our cytopathologist analyze it.
Thank you.
One last quick question.
And Nestor Villamizar, University of Miami. Do you have information on the percentage of cases that you actually changed and didn't proceed with the operation because you find benign disease despite a highly clinical suspicion of cancer?
Yes, the answer is we're looking at that now. We don't have our complete data set, but thus far, just given our high standard or high selection for these patients, we have not had to cancel a case or change our operative plan based on the biopsies. We have pretty much for these single anesthetic events, we've had pretty much a 100% sampling confirmation and proceeding with resection thus far. But we're still early in our process, and we're highly selective. As we move forward, we're going to be taking on a little bit more complex cases. So that number I expect is going to drop. But thus far, every single patient that we've done navigational biopsy has been proven to be cancer and has proceeded with surgery.
I'm just curious, before we move on, of the audience members here, how many perform some form of navigational bronchoscopy themselves, either by Veran or Monarch or Ion? Just show of hands. So maybe 30%, perhaps.
Yeah. So one of the other things is back to piggyback on your comment is. When I go to these training events or conferences about robotic bronchoscopy, I'm usually the only surgeon in the room. It's full of interventional pulmonologists. So this is definitely an area that we really need to explore and contribute to help shape the future of where this is going.
Thank you, Luis. Move on to our second presentation. This is by Dr. Feodoro Vici from the University of Bonn, who's going to talk to us about synergizing extended reality and artificial intelligence for enhanced precision and safety in thoracic surgery.
Hello. Good morning, esteemed colleagues. My name is Philipp Feodoro Vici. I'm a fifth-year resident at the University Hospital in Bonn, Germany. And I'm thanking you for inviting me here to speak at that wonderful venue. As already told, today I'm talking about the convergence of extended reality and artificial intelligence to enhance precision and safety in thoracic surgery. My potential conflicts of interest. Extended reality and their subterms are probably known to everybody by now. Extended reality is an umbrella term for virtual reality, augmented reality, and mixed reality. From now on, we will merge augmented and mixed reality because of their similarities. Important is that extended reality represents a bridge in the gap in between the reality and the digital world. At our university, we use virtual reality for student education and for surgical planning for a few years now. You can transfer a patient's CT scan into a collaborative virtual environment just within a few seconds or minutes, depending on the PACS server. We can see the anatomical structures, can window them, and annotate them as we want to teach somebody. We are now developing an on-premise XR cloud at our university, making VR easily accessible to students and clinicians all around the campus. So everybody can have a goggle in his drawer using the Wi-Fi network, accessing the patient data. In augmented reality or mixed reality, digital content is literally projected into the reality as a hologram. Here you can see a short clip of an experimental setup in our lab. On the left side, you see an illustration of how it looks from the outside. In complex cases, we use this holographic overlay to prepare for surgical procedures. The CT scan is reconstructed in 3D, then projected onto the patient. And here you can see a case of a Döge-Potter syndrome, an SFT, with quite large dimensions. We marked tumor outlines and the planned incision. Don't mind too much that flickering images. It's actually due to the experimental setup and shows us that we have a quite good overlay. In the next case, you will see a tumor of the rib, and we planned the incision. Yeah. You can see the tumor on the rib. We weren't able to see or to feel before in the clinical exam. We marked the target area and the incision line, and also a few anatomic landmarks. At the end, we were able to confirm that markings were correctly during surgery. Well, everyone has heard of ChatGPT. This is an artificial intelligence-based chatbot by the US-based company OpenAI. It's often described as the iPhone moment of artificial intelligence and has quite high relevance in our public view on artificial intelligence. AI describes a technology that makes machines think somewhat human. Exactly because of this architecture, the performance is very, very depending and on the quality and the quantity of the data it is taught with. Similar to a child who is learning by seeing everything and feeling and the impressions it's getting. When we scroll through the news, we see the topic of artificial intelligence popping up everywhere. And this is also a little bit of a hype train right now, as we are currently presumably at the peak of expectations, and depending on the technology for sure, but it will follow a disillusional phase. And it will take some time until we reach a plateau where we see artificial intelligence algorithms which are valid and you can rely on them also in the surgical field. We should be cautious not to view AI as a panacea that will bring us to Mars tomorrow. So, nor it will replace the surgeons at any time soon. Just as with the use of robotics, a bad surgeon is still a bad surgeon even with a robot. Nevertheless, this technology has the potential to help us act faster and more accurately in many situations. And we as surgeons are the ones treating the patient in the OR and bear the ultimate responsibility. As an example of how an auto-segmentation tool can look like in a virtual reality environment, you can see that we imported that image. It was auto-segmented within seconds or minutes, depending on your hardware. And but please don't mind the resolution. It's something constantly evolving right now, and we will see soon quality levels which you are used to know in commercial 3D planning tools, but with the speed of AI. Using the tool, we can remove non-relevant structures, and this is very, very useful for educational purpose, but also for surgical planning, as you already know. We apply the tools just shown in a different way also in a mixed reality environment. A mapping algorithm can help to project the CT scan and the reconstructions most precisely, quickly onto the patient's body, and can help us navigate as shown in the video before. Using computer vision algorithms, the model can learn how certain structures appear in an endoscopic image. The models learn to interpret the image. Likewise, through appropriate annotations, the model is trained to recognize surgical steps to estimate remaining time to suture. This is a figure from a group in Strasbourg. They made a few models to explain, to show these things on a sample of a cholecystectomy. Here's an example of how computer vision algorithms can be used to navigate in thoracic surgery. The collapsed lung is mapped and compared to preoperative imaging, and the now determined position of the round lesion is augmented onto the endoscopic image, allowing us and the surgeon to significantly narrow the target area for the resection. In summary, I would like to recap a few facts about the use of AI in medicine. As mentioned at the beginning, AI is data-driven. Privacy and ethics concerns make access to data sets quite difficult. In addition, the quality of the data is very inconsistent, mostly in our clinical use. Due to justifiable, very high regulatory requirements to assistance systems, the development of approved products is highly cost-effective, cost-intensive, time-consuming, and complex. Some peculiarities, such as the lack of standardized metrics, as well as unclear decision-making, complicate that even more. But ultimately, we need to know that the conscious and responsibility using this technology will improve patient safety and cannot replace the responsibility of the surgeon. Thank you for your attention, and I'm happy to discuss any questions.
Hello, Abbas from Providence, Rhode Island. Thank you so much. This was wonderful, and thank you for introducing some of the work you're doing at your institution in exploring this field. And my sense is that we're all still very early in the development phase of this technology. Where do you and your group see the next specific application, maybe in cardiothoracic surgery, for this? What's the low-hanging fruit where this can actually have an impact in patient care?
This is the chest wall, actually, for now. And when we see computer vision algorithms advance, it will also be very relevant when we are in early stages of residency for surgeons to underline anatomic structures in the hilus, for example, or nerves. So this will be the next steps, I presume.
Hey, that was a fantastic talk, super stimulating, and great work that you're doing. I know you're dedicating a lot of time to it, and thank you for sharing your work. When we talk about planning and simulation, virtual planning, a lot of times the problem that we're hearing is the the image or CT to body convergence. You showed how to use CT images to overlay on reality. How can that be adapted, or how quickly can that be done? Can you get a quick CT scan in the operating room to get an accurate image? What are your thoughts there? How long does this take to compute?
It's a development process. It takes time because the challenges are quite high on the regulatory side. We also lack an ethics votum for using the technology inside the operating room. But we will see that this manual mapping, what we are actually doing, will be more and more automated by algorithms which are in the field of computer vision, AI, which will help us to automatize these steps. And also, one slide which I showed with the deformation process of the lung, this will be also a step which will be automatized as we will understand more and more deeper the physics behind the tissue, the lung tissue. Then we can make simulations and we can apply them for more detailed models. But it will take until they will be validated and will be in regular clinical use.
And maybe in a perspective for us, you're working on this now. Is this something that we can expect to see in the next 2-3 years as a commercial product? What's your plan there?
Commercial products, probably not, but experimental, I hope by the end of the year we will have the first computer vision models in usage. But okay, we don't know how fast the industry will evolve on that matter. But it can go very fast, but I presume that due to the regulation aspects, it will take a few years. So probably 5 or 10 years until we have the really valid models. Yeah.
Great job, thank you.
Time for one quick question.
Yeah, I'm Schmidt from Bonn, from the same group, so I don't really have a question. I just wanted to comment on your question. It's probably not a low-hanging fruit, but I think one of our ideas is that we see all this great imaging, and we can find, even with regular CT scans, this, and in Germany, we're pretty soon looking at a lung cancer screening program. You guys have more experience with this. We see tiny little nodules, and every thoracic surgeon knows how it is to look for some small nodules somewhere in the middle of the left lobe, and you're like, where is it? And we've seen other ideas, like what you've shown, how to get there. And so I've always felt that we have this conflict of, in our heads, that we see this great imaging, and then we go in the ER and rely on our translational techniques. The lung has collapsed, and how do we find that nodule? And it's, I think if you're honest, we all know that you're there, and then in the end you're doing a thoracotomy, and you're just frustrated because you can't find it. And the idea is, how can AI maybe help us to segment down this very spot and help us going back to the original CT and not telling us with like 99.9% chance, oh, it must be there, but it is there because I know the lung has collapsed in this way, and we've segmented and annotated the structure. So, but I think it's not a low-hanging fruit. I think it's very high up there, but we're trying to find a way to find it, or a little step towards that. Thank you.
Thank you.
Next speaker is Dr. Rainbow Lau from the Chinese University of Hong Kong, and she's speaking on transbronchial ablation techniques.
I would like to thank the committee for inviting me here to share with everyone this exciting technology. So I've only got 10 minutes, so I don't think I can explain everything. So treat it as a teaser trailer of something coming up soon that you would like to know. Okay, let's see. Oh, green. Okay, thank you. So a bit of a declaration of conflict of interest. I have a consultancy consultancy contract with Medtronic. So this is what we hope for endobronchial ablation. So you have a nice pathway guided by whatever machine that you are using, and is a single smooth passage into the small airway, and then you reach the lesion, and then the system developed an energy to give you a good ablation zone to blast your tumor. So is it really the case? Is it like so easy? So you have all been heard about navigation bronchoscopy by whichever platform you're using, and you know about hybrid theater, mobile C-arm that is introduced by various company, and you know about there is some energy source that is available to kill the tumor at the site. But how is it exactly done? I will crack it into like 3 aspects about the navigation, delivery of the energy, and how we real-time interpretation of the ablation result and see whether you are really successful or not. So when we first start with navigation. So all the company will tell you that it's very reliable, you can get to the target lesion, it's right there. But in reality, sometimes things like this happen, and you would say, so in reality, there are some really sharp angle that is difficult for whatever system can navigate to. Some airway are really narrow that your scope can't get into. And there is this atelectasis that get things worse minute by minute that you make it very difficult for you to navigate where you are. So in order to overcome this, we started our what we call an IENB program. That is an EAP that is done inside a hybrid theater with image guidance. So in order to make sure that we reach the lesion with a very objective assessment, so what we do is UNB navigation, competency confirmation. If we are there, we are happy. If we're not there, then we will have to re-navigate. And with the extended reality, we can overlay the real-time cone beam CT image where the nodule is on the fluoroscopy. That helps us a bit more. It can help us mark the pleura so that on some specific angle that we can't really see where the pleural margin is, we can still avoid puncturing it. And we can have segmentation of lesion, some overlay of the pathway that we want to reach to different parts of a relatively bigger nodule to have a different area of biopsy or ablation. And in case there is some kind of complication happening, we can detect with CT early and act immediately. So when we get there, we need to put the catheter in situ, your ablation catheter. So of course, we have an ideal case with a lesion with a leading airway. There is no nearby blood vessels. It's not too close to the pleura, and the lesion is small. Then we're pretty happy that we may get a bullseye hit. Sorry, but some lesions are not ideal, and in fact, 90% of them do not have a bronchitis sign. So what we need at that moment is a transbronchial access tool. So this particular one is developed by the Medtronic. It's called the cross-country tool. So it has a very sharp, rigid, thin needle in the middle. So as you can see in the middle figure, that we would pass after we navigate that, we think we are there, we'll push the needle out to what we think is a suitable depth, and then we'll do a CT scan to confirm our successful placement of the catheter. Once the needle is out, it will sort of fix your catheter around there. And then what we do next is to pass the dilator that is can go along the needle, and then that will create a path for you to further push the catheter in for the ablation catheter placement. So the catheter, after being laid down, should be adjusted to give the best margin. So this is made possible only by having a in real-time CT scan. And of course, in ideal situation, we want the center of the ablation zone to be in the center of the lesion. So in some rare case scenario, when there are some adjacent blood vessel around, we don't mean to, but we may accidentally poke through some relatively sizable blood vessel that cause trouble. But don't worry, the catheter, when it's still in situ, it usually provides a good tamponade effect during the ablation. So even if you do detect that there is some potential injury to surrounding vessel, if situation allow, you can still proceed to your catheter placement and ablation. But the real bleeding is, it happens only after you really remove the catheter. So in that case, you still have time to rush to get your whatever rigid bronchoscopy, get your anesthesia ready for some major airway bleeding. And one trouble is that after you have some hemorrhage, the CT scan is going to be all fuzzy with the hemorrhage and make your ablation interpretation a bit difficult. When the target is small, then it's difficult to hit the bullseye of the target. But the good thing is that if your product has, your ablation catheter has a good ablation zone coverage, then you still get a successful navigation even if you don't hit the lesion. But how about if the lesion is relatively larger, having an unfavorable shape or texture like the one that is on the right-hand side is completely calcified osteosarcoma, no catheter can go through. Even if you take it out, cut it with a blade, the blade will crack. So if you have a larger lesion, but if its shape is along the angle of the airway, then you can still use this. Can we try to play the video on the right-hand side? So doesn't work here. Oh, here. Great. So you can first put the catheter in the more distal aspect of the tumor. And when you're done, you have a more distal ablation zone. You can pull back a little bit, do the ablation again. That will give you a good ablation coverage. And if you can't really skewer the lesion, try it the Asian ways. Use the chopsticks. So we do bracket ablation when we can't really poke through a lesion. So you go around the lesion, be it 2 ablation or 3 ablation, to achieve your planned ablation margin. So having a bracket ablation, they give you a larger margin, but it's more time consuming. That will mean actually more like a lot more radiation exposure as well. And it has a theoretically higher risk because you have to do multiple puncture, and each puncture, like into the lung parenchyma, potentially can cause hemorrhage, pneumothorax. Yeah. If your lesion is too close to the pleura, you may need to go slow because we do not want any pneumothorax. And you can let the forward flow of microwave energy do the job. And because when we have the pleural puncture is very problematic, you need immediate drainage, and your navigation will become more difficult. And there is a potential problem of bronchopleural fistula. And when the patient wakes up, he or she won't be happy because he or she expects like he can go home the next day, but now he's stuck with a drain. And when it comes to delivery of energy, so we know that ablation mechanism, fire and ice. So we have RFA, microwave, and cryoablation being the more commonly investigated modality. And what we think is that microwave ablation is the game changer in this recent era of endobronchial ablation, because you can see on the left-hand side, the microwave ablation zone gives you a much wider coverage. And I want you to also notice that this lump of liver tissue initially was not fit with the box, and now the whole thing has shrunken to leave a gap here. So for the interest of time, I'm not going to go through how microwave kills. And this is the ablation zone that Amprint catheter from Medtronic came to give us, but this is of course not live lung tissue. So a typical ablation zone on the CT scan 10 minutes after a 100 watt of ablation looks like this on the right-hand side. So you can see the tumor in the center of the lesion is kind of look like when you microwave your food for too long, it's got dried up, shrunken. And around there is a halo of ablation zone. This is what we call a relatively good ablation zone and good coverage. However, we do see some miserably small ablation zone, which we call it under ablation, but also some monstrous post-ablation cavitation. So we don't have too much idea at this moment what exactly led to this very interesting phenomenon. Some people think it's related to what we call heat sink effect, when there is some adjacent big blood vessel taking the energy away, but it doesn't always correlate with the ablation zone. So we think that it may be that the temperature of the tissue didn't reach the killing point, and if we have real-time monitoring of the temperature, it will be much more satisfactory for the operator to know whether they have killed the lesion or not. And when it comes to the intraoperative CT analysis, it's kind of like looking at the night sky. So the blood vessels are the stars, and the background lung tissue are the black. So people often ask, oh, how many CT scans do you need to do one ablation? So in a very ideal situation, what we do is a pre-procedure CT scan for real-time localization, augmented fluoroscopy, and then we start to navigate with or without the augmented fluoroscopy guidance. And the next CT scan, which is to confirm successful navigation, and will move forward to insertion of the ablation catheter. So because of the change on the ventilation or some atelectasis setting in, the first two CT scans already show some differences. As you can see, I'll have to adjust a lot of time how the CT is matched to each other for us to confirm that nodule is around there. For a solid lesion, you may not need to do that, but we're treating a lot of ground glass opacity. It may become very difficult to see it. So, and after the successful deployment of the catheter, and you don't need further adjustment, you may proceed to press the button and do your ablation. But you have to make sure that the planted ablation zone give you a good coverage, as well as make sure that it's not too near to some important structure that you don't want to burn. You may need to lower your ablation energy or time to avoid damage to this area. And on the left-hand side, two photos that you can see, it's the energy can cross the pleura and cause damage. This patient do have a bit of phrenic nerve palsy for a few weeks. And ideally, the last CT scan, the fourth one, is that will assess the ablation change after the ablation, confirm that it gives you good coverage, and then the case is done. But that is not the reality. If you have a large tumor, no bronchial sign, close to big blood vessel, so the first CT scan is still the pre-procedure one, but when you start navigation, then you may have to re-navigate, move the catheter a bit, re-navigate again, so you don't want to be stuck in the hybrid theater on Valentine's Day doing 24/7 CT. It's kind of painful. So if the ablation zone look like this, matching the planted size, is, of course, everyone is happy. But sometimes the zone can look small, but you have to look in it more carefully to confirm that it is actually an adequate ablation. So I'm usually the guy in the chair working on the computer while Calvin, my colleague, is doing the job, and hopefully we can go home on time. Yeah, there's a few minutes. So I would like to thank Professor Calvin, who lead our team for all these advancement that we're doing, and Dr. Joyce Chan, who is here, and she did a lot of the paper. She wrote up most of our publication. So the legendary endobronchial ablation is not return, it's coming. So we haven't talked about the follow-up and how it changed. So a little advertisement here. We're going to have our second bronchoscopic ablation summit in October this year. So I hope you stay for the day. We'll welcome you in Hong Kong. Thank you.
Perhaps we have time for just one quick question.
Thank you. It was an outstanding presentation.
Just remind.
Yeah, I'm Ghulam Abbas from West Virginia. First time we used imprint was 2007, and the first meeting we had with Medtronic for using Super D and transablation microwave was in 2007 and it took like 17, 18 years to come to reality. I mean, this is all great, but I will remind you, using Imprint for microwave ablation, I had 2 patients where we used to do percutaneous CT scan, and they bled to death 2-3 days later at home. I remember 2 at least patients with microwave ablation. So when we're doing these transbronchial ablations, you have to be careful. They look small nodule, they look small vessels. You're creating a communication between the bronchus and the vessel. It may not bleed that day, but they may bleed later in the day. Second is between RFA and microwave ablation is definitely a better tool because you don't see the heat sink. It kills the tumor by boiling the water molecule as compared to the RFA where you can see a heat sink and you may not get the target. And the other issue is close to pleural. Microwave is worse than RFA. You get more bronchopleural fistulas. I had 2 or 3 patients I had to take back and do a wedge resection for persistent bronchopleural fistula after percutaneous microwave ablations. So these are all look good, but you have to be very careful in patient selection.
Thank you very much for sharing your experience with us. I would like to give further comment, but for the interest of time, I'll answer your question maybe in Hong Kong. Thank you.
Okay, we'll move on to the next presentation. So on the official, on this printout, it says that we have a presentation by Natalie Liu, but I don't see her on.
Dr. Jean Zhao
Okay, yes, so that must be, okay, perfect.
from Ohio State University.
Dr. Zhao is going to be talking to us on fluorescent-guided GGO nodule identification.
All right. Good morning. Thank you for the opportunity to present. As Dr. Rice said, I'm Jane Zhao. I'm a fellow at The Ohio State University. Today, I'll be discussing fluorescence-guided ground glass opacity identification. I have no disclosures. Ground glass opacities, or GGOs, present a conundrum for thoracic surgeons. They represent a broad differential of disease processes that range from benign to malignant. GGOs that have a persistent or enlarging solid component often turn out to be an indolent adenocarcinoma or a precursor in the adenocarcinoma spectrum. GGOs are difficult to palpate and frequently heterogeneous, so biopsy options can be challenging and low yield. Even in the setting of a negative biopsy, clinical suspicion is usually enough to warrant sublobar resection. During surgery, identifying where and what to reset can be difficult. Furthermore, given the long latency period, it is hard to know how aggressive the potential underlying adenocarcinoma may be, and thus how aggressive to be with lymph node dissection. We know that for pure GGOs, lymph node metastases are virtually non-existent. For ground glass predominant nodules, lymph node metastases are about 5%, and for solid predominant GGOs, lymph node spread is about 8%. As such, it is up to surgeon discretion for how aggressive to be with lymph node sampling. There are various methods for biopsying GGOs. However, the yield is suboptimal, especially for smaller lesions and in the absence of a significant solid component. What we know from transthoracic needle biopsy is that the yield can be as low as 35% for sub-centimeter GGOs. New technology has been developed, but we do not know much yet about their yield. In this slide, you can see example images of the blizzard sign, a heterogeneous appearance on radial EBUS, which is pathognomonic for a GGO. And you can also see a picture of the ion platform. Because preoperative biopsy is so low yield for GGOs, many do not even bother with it and simply offer the patient surgical resection. However, even then, it is not that simple. Many GGOs, particularly those that lack a significant solid component or those that are less than a centimeter in size, are difficult to localize, as we've heard from our previous presenters. This is especially exacerbated with the increasing use of minimally invasive surgical options, such as that of the robot or VATS, where you are dependent on visualization and not palpation to localize the GGO. Conventional hook wire, spring coil fiducials, and methylene blue injection are options, but they also have complications related to slippage of the wire, pneumothorax, air embolism, and dye dispersion. Endocynin green, or ICG, has started to gain popularity in thoracic surgery as it can concentrate in tumor tissue, does not damage the surrounding lung parenchyma or affect pathological diagnosis, does not trigger allergic reactions, and can provide information in real time. We are starting to see an increasing use of its application, both via transthoracic injection and via navigational bronchoscopy. While the use of ICG is catching on, there really is no established standardized technique for its use in localization of GGOs. We reviewed the literature and found a variety of injection methods, with differing quantities and concentrations of ICG used, injection needle size, and even whether or not saline or air was used to chase the ICG after it was administered. Clearly, there is still a lot of room for standardization. Here, we present a case study of a patient with bilateral upper lobe GGOs in which we use ICG for localization. We have a 68-year-old woman with a history significant for tobacco use. She had bilateral upper lobe GGOs. The left had more of a solid component. A preoperative biopsy was consistent with an adenocarcinoma spectrum lesion. The right upper lobe GGO also had a small solid component, but this was not amenable to percutaneous biopsy from our IR colleagues. Here are axial cuts of her scan. You can see the bilateral GGOs in the upper lobes. And here are the other views, the coronal followed by the sagittal in a little bit. We discussed the various treatment options with our patient. The traditional model would have been one where we would first go after the left-sided GGO with a sublobar resection, let her recover for a couple of weeks, and then bring her back to perform a sublobar resection of the right-sided GGO. The alternative approach would be us offering her a streamlined process, using navigational bronchoscopy for localization, and then performing sublobar resections of both GGOs under one anesthesia. The patient was understandably anxious and opted for everything to be addressed all at the same time under one anesthesia event. This was our plan for resection. We would perform a wedge resection for the right upper lobe lesion with intraoperative localization using nav-bronch, and followed by flipping her on her other side and doing a robot segmentectomy for the left upper lobe GGO. So we started with the right upper lobe GGO. We used the ion endoluminal system to localize the GGO using fluoroscopy and radial EBUS as adjuncts. No radial EBUS signal was present, but that was fine since we were otherwise fairly confident we were in the correct vicinity. We injected 0.4 cc's of ICG. We then chased with a few puffs of air to make sure none of the dye was left in the catheter. The whole process probably took a little over 10 minutes of our time. We then positioned in left lateral decubitus with right side up. We docked the robot using the standard forearm setup with ports placed along the 8th intercostal space with an assistant air seal port in the 10th intercostal space. Firefly was used to identify where we had tagged the GGO with ICG. We then performed a deep wedge resection with no plans for frozen analysis. We finished by harvesting N1 and N2 nodes. On the other side, we followed the same robot setup with 4 ports in the 8th intercostal space and an assistant air seal in the 10th. We performed a lingula-sparing left upper lobe trisegmentectomy. We performed an N1 and N2 lymph node dissection on this side as well. The patient did well. She was discharged on postoperative day 1. She was seen in clinic 2 weeks later, at which time she happily gave consent to have her case discussed. Her pathology came back with both GGOs harboring adenocarcinoma spectrum processes. All lymph nodes were found to be negative. In conclusion, there is a lot of exciting innovations happening to help streamline the process for workup and management of GGOs. We have the capabilities of using navigational bronchoscopy and ICG to localize GGOs. Multiple localizations are now possible for sublobar resections. We have the option of on-site cytopathology to give us answers right away, should we want it. All in all, thanks to these robotic technologies, we're able to provide much more patient-centric treatment options, such as offering the ability to provide definitive resection of synchronous bilateral GGOs under one anesthesia. Thank you for your time. I'm happy to take any questions.
Sebastian Gilbert from Ottawa, Canada. Thank you very much for the presentation. I enjoyed it. There's localization, but there's also like helping us guide the depth of our sublobar resection, if it's a wedge particularly, maybe not so much for a segmentectomy. Radio-opaque markers help with that. Any advice or tips and tricks for ICG location with regard to how deep you need to go, because the edges of that lesion will not be visible or palpable, obviously, those ground glass that you showed on your CT scan.
Yeah, no, absolutely. We found that a centimeter worked well for us in terms of depth. And then, like you said, there are definitely fiducials available, like spring coils soaked in ICG, that can act as excellent adjuncts to help with, palpation of the lesion after the specimen is out of the chest, to help you see if you have adequate margins.
Thank you.
Hi, Lana Schumacher from MGH. That was a great talk, very inspiring. And I just wanted to ask a couple questions, or just one question. You had mentioned the ICG-soaked coils. Have you been doing that? And I think that will help, again, with depth, like Dr. Gilbert just mentioned. And then just a quick comment, too, if you want to mix your ICG with a little colloid or patient blood, it actually stays longer as well. So it's just a little trick, but I just was curious if you can expand more on the ICG with the coils that are soaked.
We have not, but
you haven't
we
done
know
that.
there was recently an article that was published, and we look forward to having more patients come through.
Great.
So we can try that out.
Yeah, thank you.
Absolutely.
So what is your current ICG recipe then?
So we
Concentration and
put in 0.4 cc's, and then we chase it with a little bit of air.
but 0.4 cc's of what concentration though?
I think it was 0.25 milliliters per mg. Yeah, he's nodding. Yes.
And this is sort of a philosophical question. You marked both sides, is that right?
No, we just marked the right upper lobe.
Okay.
The left one, we knew we were going to go after it with the lingular-sparing trisegmentectomy, so there really was no need.
That was sort of my point, that if you know that you're going to do the segment and you anatomically know where that lesion is, do you need to mark it? And I agree with your approach. Thank you.
Thank you.
Our next speaker is Dr. Yolanda Colson from Mass General Hospital, who's going to be speaking about near-infrared sentinel lymph node identification in non-small cell lung cancer.
Thank you very much. One of the things I was going to add, and we can talk about it in the discussion, is ICG depth of penetration visualization is not very deep. So you can't do deep lesions and see it. So you have to be towards the surface. There's a limited amount of depth, and I think that's one of the things we can talk a little bit about that. I have the disclosures that we actually started this. We've done all this work in clinical trials, and we did it as an equipment loan. They have no oversight of data review or payment or anything else, but I think that's important. And then I have a non-related one doing some work with a sponsored research agreement with Canon. The other disclosure is I don't have the perfect system here. I don't even claim it, but I think we've learned a lot. And I think it is something that we need to think about. And I think there's a bunch of stuff that I'm going to share that we've learned. And I think the reason for the discussion about the sentinel nodes is particularly important right now because of this discussion about going to sublobars and segments and wedges. And if you really look at those papers that are coming out, the importance of what are the nodes and the status of the nodes is really important. And everyone thinks, oh, we can just go to this. But if we don't really look at the nodes, we're going to be back where we were way back when, right? So we know that survival is dependent on the metastatic nodal disease, and we know that even if it's localized, that the survival isn't 100%, and we know that's because we can get recurrence, and that a number of those patients will actually get recurrence. And we know that that has to do somewhat with missed nodal disease in many of them. So where do we miss nodal disease? Well, we miss it by either preoperatively, that we don't actually, we clinically stage them, and about 18% of clinical stage 1 patients actually on final pathology are upstaged. At the time of surgery, this is a problem that we've had within our field, where only about 50% of patients actually go undergo formal lymphadenectomy or lymph node staging, and I think that's going to really accelerate as we talk about this idea that we can do wedges for smaller things, and it's like that. I think it's going to be really important because the wedge studies that have been done in the past show we're even worse at doing lymph nodes. And then on pathologic analysis, even if we do them, node negative patients, there's about a 16 to 18% if you just look at pathology. If you go back and scrutinize the nodes beyond routine H and E, you have 16 to 18% of those that are actually node positive patients. And that becomes important because then we have to decide, when you look at the data about node sampling versus lymphadenectomy, there hasn't been a lot of difference in survival in several of the studies, but you still have to have the more nodes you take, the more likely you are to find a positive node. So the question is, do we have to have every node, or do we just have to find the right node, which is the idea behind a Sentinel node? Can we increase the chances of finding that right node? And so the potential of Sentinel lymph node technology is to decrease missed micrometastatic disease by trying to find the node that's most likely to harbor metastatic disease and scrutinize that node. And that was the initial impetus behind this. And then to achieve accurate staging, to allow it, and then if you have multiple lung cancers over time, ultimately, it would be nice if we could go in and take the specific node as opposed to your first cancer, you get to take all your nodes, and then after that, you don't have any way to sample anymore. So I think as we evolve, it's going to be important, and we then better select who should get lobectomies, who should get segments, who should get wedges based on that. This is kind of the history of the Sentinel lymph node mapping over time that's been done. It's been done for many, many years, and you can see that the success rates vary quite widely depending on the studies and how they're done. And it can be with the isosulfan or radioisotopes down into the ICGs, and then looking at near-infrared ICGs. And you can see it varies quite widely. And I chose the technetium studies because this is kind of some of the early stuff that actually got into phase 1 trials. They did a CALGB trial, and you can see that the rate of identifying sentinel lymph nodes varies quite a bit, but then the accuracy, meaning that if you found a node and said this was a sentinel lymph node, was it consistent with the rest of the nodal basin, i.e., if the sentinel node is negative, are all the nodes negative? Because if that's not, and there's a node that's positive that's not the sentinel node, then it's not the sentinel node. So it's this discordance that becomes really important that we look at. And then what's your overall success rate of actually finding it? And there's some really important learning curve and learning anatomy that we didn't really appreciate at the time. So we got interested in using near-infrared fluorescent imaging for a variety of these reasons. One, there was a pretty high signal-to-background ratio. The autofluorescence wasn't as high. It's very hard to do radioisotopes within the hilum, particularly in a minimally invasive approach. It has good tissue penetration. I could mark the nodule at the same time, and you could do real time so that a camera actually can fuse from the light source. You get your near-infrared, and you can see as well as look at that. To be honest, I've not found the Firefly very good on the sentinel nodes. You can see the nodule, but you can't see the track, and we can talk more about that. And then the fact is, if you don't have the camera on, you can't see the dye, depending on how much your dose is, so you can it doesn't distort your field, and then we didn't have the radioactivity risk. Now, we did 2 different approaches as we learned this. It's taken us, this is almost a decade worth of work. Looking at transpleural injection was how we initially started. You could palpate the lesion, you could inject around it with the idea that then you could see where your lesion was, you saw the lesion, and then we could track to where the lymph node, lymphatics ran. The problem is you're poking a hole in the lung and it's deflated. And if you try to inflate it, and there's some things I can talk about during the discussion about inflating or not inflating the lung and what that does to lymphatics. But if you do that, then you end up getting intraoperative spillage, which can make it challenging. So we've had better luck, and I'll show you the data on navigational bronchoscopy because we don't have a hole in the pleura. We get minimal spillage, and it allows us to mark some things that are non-palpable. We've got our dose down to about the 2.5 milligrams. The difference is we found it important to mix it with a colloid. So we tend to do it with albumin, and that tends to be, at least my belief is, that it slows it down a little bit and keeps it together as it goes through the lymphatic pathway, because otherwise it goes so fast, it can get hard to lodge it in the lymph nodes. Here's a video of us going through, looking at one of these smaller ground glass nodules. We did it by, this is the one where we've done with navigational bronchoscopy, going down. At this point, we were using the C-arm in order to identify where we are, and we would inject this dose of ICG. We did a whole dose titration, and you can see the lymphatic mapping in this case where it goes over top the surface along the subpleural lymphatics, and you can see that blush. And so what's interesting, this happens to be a level 5, you open it up, you can see that you don't have a lot of spillage elsewhere, you can see where they are, but not all the nodes are green, which was important because it means not every node is the sentinel node. And so you could take out the ones that were green and you could scrutinize where they were. The ones that weren't. In this study, I did lymphadenectomies and took the other lymph nodes because I thought it was important to make sure that we had the nodes that were positive were the sentinel nodes and vice versa. So they went to the pathologist. They didn't know what they were. I just randomly numbered them by station, so we didn't completely mess this up. But it would be a level 5 node, but I would say 1, 2, 3, and 4, and they wouldn't know which was green and which wasn't. This was kind of a composite that I put together. So one was getting the dose right, because we started way lower in the animals. You didn't need to have as much dye. We had to have a much higher dose in humans when we did dose optimized and non-dose optimized, and we started out doing them all transpleurally. And we did that, what we found with the intraoperative spillage, having single lung ventilation, the lung down, we ended up where we were in the 40s to 50% of overall, did we find a lymph node or not? And we'll talk a little bit about what that was. What's interesting is when we switched to navigational bronch, where we didn't have the spillage, we got better targeting where we were. We ended up at about 78%. And I think it's because we could target it better, we got a more concentrated dose that was there, and I think we could navigate to where it is. Now, not all of these, though, can you see the lesion on the surface, because if the lesion's deep where you put your dye color, it doesn't get to the surface. There's only so much signal that you can get through. So then you're marking it to do your dye study, but you don't necessarily have it there. So if you look at all cases, we're at about 65%, but I favor the navigational bronch as being much a better way to do this. Now, this is where I think we learned a lot. So we went through and tracked every single lesion that was injected and where it went to which node station. And this is where we started to really learn about the anatomy, because if you look, the same lesion isn't going to the same nodes. Some are going to N1, some are going to N2s. They're roughly in the vicinity, but not always in the vicinity. And I'm looking at a vat, so I don't look on the other side. Our thought is it's not very often that it goes to the contralateral side, but theoretically, I suppose you could have some trafficking. I think that's extremely unlikely. And much of the data that's been looking at where metastatic disease goes from a lesion to where you find it, we don't find it very often in the contralateral side. So I do think this is helpful. But one of the things to think about is, why is there such variability in a single lesion in the left upper lobe, say? Why is it going to multiple different stations? It's not like breast cancer where it's pretty clear where it's going. And that's because this was pointed out to me by Tom Egan. Actually, there are different systems of lymphatics in the lung, and we don't necessarily think about that. There is a subpleural superficial, which you saw in the movie, and you have a deep lymphatic plexus that runs along your bronchus. So depending on where your tumor is located, you can get a pretty high rate of skip metastases. Skip metastases being going to an N2 node. And so we actually had patients that all the nodes are negative except for a single N2 node that we found that was green. And so I think this is going to become really important when we start talking about wedge resections and segmentectomies and figuring out how to do this better. And we need better tracers is the answer, but I think we're going to get there. And I just thought it was fascinating because I had never been really taught that there were different ways that the lymphatics go depending on the depth of the lesion. And so what we did is we started to think about this, doing our injections, going through, doing our complete lymphadenectomy dissections and imaging each node to figure out what was the sentinel node. Now, what's interesting is when we did this, if this is the percentages of patients on the x-axis, we have the sentinel lymph, the near-infrared identified sentinel lymph node. So the green node gets identified on pathology. And of this subset that we had the right dose, that we got the answer and did that, we've optimized the patients. 22 of those sentinel lymph nodes that we took out were negative. Every other lymph node in the specimen was negative. So it is predictive when you get it. If it's truly negative, those patients, we've not found metastatic disease in other lymph nodes. If the lymph node, the sentinel lymph node is positive, then the disease is positive. And we had 8 of those patients, even though they'd already been staged, these were thought to be early stage and thought to be by EBUS and everything else negative. 8 of those patients ended up having disease in somewhere in the lymph node specimens. All of them had a positive near-infrared sentinel lymph node, at least. 4 of them had only the sentinel lymph node being positive, some of them micrometastatic, and the other ones had the sentinel lymph node plus other nodes, which doesn't surprise me. Once it's out, right? And here we can see what's interesting in those patients that did have the only node being the sentinel lymph node with metastatic disease. Some of them were micrometastatic. They got treated and they're actually still alive, which is actually great because they got treated earlier. Now, what happens if you have a sentinel lymph node that you took out, it's negative? What we found were these were patients who had wedge resections or limited resections, because that's why I started this study, because I wanted to know if there was a way to figure out that you could do wedges. And this, if you look at the follow-up, this is 10-year follow-up. And so they've not had recurrent disease, and they've not had metastatic disease show up in this cohort of patients. And that has actually been good. They may get a second primary somewhere just by default, but I've not had this group of patients recur. The blue line are those that were selected in the study the same way, but I either by dose didn't find the sentinel lymph node because I was still doing my dose escalation, or we didn't identify the sentinel lymph node, and even though we did the nodes, they were thought to be N0. But this pretty much follows, and some of them are pretty good-sized tumors, it follows with what we would expect by their stage to be their recurrence rate. So it follows the historical, but we did select out a group of patients that didn't seem to recur. So what's the potential? There's a decrease missed micrometastatic disease if we can focus the pathologist on that sentinel lymph node. And it's probably a little bit higher predictive, but and especially if we find it only in the sentinel lymph node, it really focuses us and tells us those patients that we missed, especially since some of them are stage 3. And I think that becomes important. Accurate staging, can it alter how we have to sample things? Can it make it faster? Can we actually focus? But we need a much bigger trial, and we need better ways to get our dye to go where we need to in order to do that. And then hopefully it would decrease recurrence, okay? Challenges, we don't get the sentinel node every time. This got held up by COVID and our ability to enroll patients during clinical trials in this with airway and the amount of time that we needed to go in and navigate. So we didn't do a lot of the navigational bronchoscopy with research studies. So we're getting this all restarted and reprimed. There is this difference. I think we have a lot to learn about different lymphatic pathways. So you don't see it in the breast. You don't see it. It works great in the head and neck. It's harder in the lung and in the esophagus, are both different. And I think what we found is if you inflate, and that's why I think the navigational bronch works better, when you're inflating the lung, you get better lymphatic flow through the lung than when you do when it's collapsed and you're not actually ventilating it and you're not doing that. So I think we've learned a lot there. And then the operative time, just the hassle of having to go down and do it, I think is something, but it doesn't actually take that long to go down and mark the nodules. You have to have a really good camera that can see the fine detail of where the lymphatics are going, and you can see that blush. You have to have a really good camera to see the blush of those lymph nodes. And then the last slide is really just looking at these near-infrared negative nodes, I do think there is some improvement, or at least our ability to predict who's truly negative, which will be useful with the new data and new paradigms that we're talking about. And then maybe we can focus our nodal sampling. I think it's really going to take a lot of work and people to really follow their answers about the long-term efficiency and safety data. I think we need to kind of, as a community, come together to do that. I want to thank you for your attention and open to any questions.
That was an excellent talk. We've got about 5 minutes in the remainder of this session, so we'll open it up for discussion.
Hi, Dr. Colson. Thank you very much. Nestor Villamizar, University of Miami. I have found this work fascinating, and thank you for all you've done during the last decade. One of the concerns that I would have, for example, in the case that you show with the mediastinal lymph node 5, if you are trying to do a wedge resection, so the timing of the injection and how it travels, how confident are you that you didn't miss like a level 13 lymph node because you found already the dye, all the way in the level 5?
Well, that's why I think it's really important, this mixing with different amount of colloid, because it does slow the transit a little bit. If I just do it in the saline, it'll go through and I can miss it. And I think that's part of why we don't find sentinel lymph nodes sometimes, is figuring that out. And so one of the things is to start trying to figure out how can we mix that better and how can we slow that down. It's a little tricky in the sense that it seems to stay there for quite a while. So I don't think it ran through the 13 and sat at the 5 and it sits in the 5 for an hour when it was a few minutes in there. I tend to image while I inject it, and I tend to image as I go. And I try to look at different time points to make sure. And usually you can see it run pretty directly and it'll go to one site and do. The track's really important and we don't always see it. So you're right, I don't know. I just haven't found it by the data, that if I have a node and it's positive or negative, it's not like I find it when I did the lobe or I did the resection or I get a recurrence. So it's implied by the fact that I don't get a node show up 5 years later, right, to tell me I didn't miss it. That's my only way to know.
And do you have any information in, like, let's say that you had a nodule in a specific segment in the left upper lobe, that you actually found the sentinel lymph node in a different segment, in the same left upper lobe, but in a different segment that where the tumor was located?
So I haven't found it. And so some of these patients did have a lobectomy. And when we looked through, we imaged it and didn't find like a sentinel node somewhere else and another lymph node that was green in deeper, right? It tended to stay in that sentinel. Does that help what I'm saying? And it doesn't seem to be different segments.
Great talk, Yolanda. Sid Murthy, Cleveland. Your fidelity of lymphatic drainage, it probably tracks with the density of diseased lung, just like blood vessels.
Yeah.
So if you do quantitative CT scans on most of the people that we operate on, you will find unbelievably heterogeneous lungs and emphysema. So I think, unfortunately, like fissures, they fuse as we age because of inflammation. I think lymphatic fidelity and drainage changes. So you have different people with emphysema with the same nodule, they will drain different ways.
Exactly.
So I don't think you can ever get around. I don't think you can build a workaround for that.
No.
I think this idea of sentinel lymph node in lungs, I think that one of the points is that an N1 node could be 14, 13, 12, 11. You're going to sample 11 most of the time when you do a lymphadenectomy, let's say, even doing a wedge. But if you're doing a segment, you're probably going to get 12, but you're not going to get 13 unless you're really high into parenchyma. You're not going to get 14. But statistically, survival is the same whether it is level 11, 12, 13, 14. So I think we have to step back and think about sentinel lymph node. What does it really mean? Because if you go back to the lung cancer study group and you go back to even the recent El Torki papers, how important is it to pick up sentinel lymph node positivity when it's micrometastatic, when we can potentially salvage people with recurrences, with SBRT, with immunotherapy, with something else? So should we, on these wedges, change the surveillance to follow these people every 3 months with CT, not every 6, because you're looking for early recurrence, because that's when you can intervene. You're not looking for systemic disease, you're looking for early local disease, and maybe that's what gets those curves to superimpose later, is that we're salvaging people. And then the last thing that I was thinking about is that with the robotic platforms, the complete lymphadenectomy at some level gets the workaround for having this heterogeneity in terms of some of the N2 Sentinel nodes that you're finding, whether it was, most of the people, if you look, we wrote a paper on upstaging with the robotic and the NCDB database, and you upstage far more greater with a robotic lobectomy because we think the lymph nodes are being pulled out. So, you're taking the whole group. Is it really a negative aspect of doing a full lymphadenectomy? It's not like the axillary lymph node dissection in the arm where you're getting massive lymphedema.
No, and that's not my point. I guess there's 2 points. One, I think if you do it and you find a sentinel node, and that sentinel node is negative, it does give you some prognostic information. And is it that group that we say we can do every 6 months, you don't need one every 3, because we've never seen that group recur even with a wedge, right?
Yeah, but you're 50-50 here, because 50% of the time, your sentinel node was the only node, 50% it wasn't the only node.
No. When the sentinel node is negative, they have not had metastatic or recurrent disease.
I see.
It's selecting a group that we can probably follow less close. That's some value. There's a group, 40% of them, we don't find the sentinel node for whatever reason, lymphatic, however it is, which puts us into where we are now.
Okay, but if you were to have found that the sentinel node by chance because you did an extensive lymphadenectomy, you would be in the same place.
No, you're not. Because when you look at the survival, I did the lymphadenectomy, and they have the historical recurrence that a percentage of them will recur because we miss the micrometastatic disease because we don't look at every node. That's the thing. There's kind of our historical, do a full lymphadenectomy and find out what you can find, which I think is where we are now. And the question is, can we pull a subset of these out that we say we actually know their chances are better?
Fascinating. Thank you very much.
That's the difference, yeah. You good?
Abbas from Providence, Rhode Island. Thank you, Yolanda. Excellent work. I just want your advice here because I don't want, I think, the message that we should all be injecting ICG and looking for sentinel lymph nodes.
No, I think we need to.
You have a very specific protocol. I wonder how exactly you prepare it, and if we can emulate that, should we be attempting, all of us, to look at this possible sentinel node and combine our data?
No, I think what we're going to have to do is set it back up, and I think we're going to have to do some clinical trials. We can see what happens with the stage, the CALGB trial, those trials that get done, they're always harder to reproduce and to look at that. So what my proposal is to say, I do think it's worth talking about. I do think it's worth thinking about how we do it, particularly with the new information that's coming out, because I think I still, in all of these trials, still did lymphadenectomies. And I think all of us need to do the lymphadenectomy. I think it is a way of looking to try to learn more about lung cancer, learn more about what we have in metastatic disease, how does lung cancer work. And I think over time we're going to end up where, here's a subset that is a good actor and the ones that are different actors. Right? I think if you don't have a sentinel node, even if it's perfect, you got to do a full lymphadenectomy. And I think right now we have to all do it.
I have one other question. So the concept of nodal preservation is new to me, but I do see the benefit of
being able to stage the second lung cancer.
I do see the benefit of doing a sentinel, of trying to identify a sentinel node, because you can section that,
that's the point.
Sections, right?
Right.
How many patients did you find that by sectioning it multiple times, rather than just taking a single section, which is the standard, that you actually found metastatic disease.
So the study that was done before us, where they literally went back and said, here's our answer, these are all node negative, and then they went back and said, now we want you to go through and microsection all of these, that's where they came up with the 16%, that we probably miss it. Now the question is, do all of those, with the idea that micrometastatic, do we salvage them anyway, do we not? I think that's what we're going to have to look at. My concern is we'll do these wedges or things, and people aren't actually taking full lymphadenectomies, and we're all going to say, oh, but the data says you can just do a wedge now, and we're not sampling. And my real message, we have to look at the nodes. Sentinel nodes are great, but we got to look at the lymph nodes.
The problem is that the surgeons who are not vested in performing a detailed radical lymphadenectomy are probably the same surgeons who are not going to be interested in doing this.
Correct. Correct. And so it's, can we learn, can we get better information out of our lymph node sampling is really what this is. It's really what I'm trying to do. Is there a better way for us to get more information to do it? It is not something that I'm going to tell everyone to go do, because there's a learning curve and it's tricky, but I think there's enough interest that I think I can get people to kind of start to invest it and start thinking about how we do a multi-center trial to do it.
It also shows the point why you don't do a segmentectomy for a clinical stage 2A that has pleural involvement, right? I mean,
right. I mean, I'm fascinated by the lymphatics.
Impressive.
Okay. Thank you.
Great. Thank you very much, all the speakers and the audience. And we'll resume at 10 o'clock, I think.